Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about osteoporosis. Osteoporosis is a very common medical problem. Worldwide, there are more than 200 million people who have osteoporosis. In this country, some 44 million folks suffer from osteoporosis. And osteoporosis is more common in different ethnic groups. It's more common in Caucasian, more common in Asian, and less common in Negro folks because Negroes have a bone density that is stronger and denser than all other ethnic groups. As a result of that, the incidence of osteoporosis is much less. All of us, as we grow older, we're going to develop some degree of osteopenia, osteoporosis. That's just part of the aging process. However, there are conditions that predispose people from developing osteoporosis at a younger age. And I'll go through the list for you again. Smoking, alcohol abuse, low dietary calcium, vitamin D deficiency, lack of exercise, malabsorption, malnutrition, the postmenopausal state, and chronic use of heparin, primary hyperparathyroidism, secondary hyperparathyroidism, chronic use of steroid, kidney failure, Cushing syndrome, thyrotoxicosis, calcium deficiency, systemic mastocytosis, rheumatoid arthritis, scurvy, rickets, homozygous osteogenesis imperfecta, heterozygous osteogenesis imperfecta, hemochromatosis, Marfan syndrome, gigantism, multiple myeloma, etc. Now, the condition that you probably never heard of before, the general public, that is osteogenesis imperfecta. That happens to be a hereditary congenital problem that infant can be born with if they're homozygous, and if they are heterozygote, they may have osteogenesis imperfecta causing severe osteoporosis after you've exhausted all different forms of evaluation. And then if you are inclined to keeping this thing in mind, then you might begin an evaluation to find that you in fact were born with a congenital problem that you didn't know about because it was heterozygous. If it were homozygous, you would know since infancy. So it is so complicated. And look at the list of the different diseases that are outlined for you that can cause someone to have osteoporosis. So this is a serious, serious medical problem. As I mentioned in the previous shows, when one has osteoporosis, it is very dangerous to just give somebody a prescription and go and do a bone density, and the result comes back, you have osteoporosis, and then you just take your prescription pad and write them a prescription for medication to treat it. Extremely dangerous because there are so many serious and many instances deadly medical problems that can first present as osteoporosis. Therefore, it is clearly necessary when you see a patient with osteoporosis, you have to do an extensive evaluation before you begin the patient on medication for osteoporosis, or else you might wind up missing some major medical problems that the patient may in fact be dealing with. So last week I began to talk a little bit about the evaluation, and I'll continue that again in this segment. Namely, you take a history from the patient. They're talking about bone pain, arthritic type pain, and then multiple different fractures. People have fractures that didn't fall or anything like that, and yet they wind up with spontaneous fractures. Right away, that is a red flag. And as I mentioned last week, after you do the complete physical examination, you will do a complete blood count, you will do a complete chemistry profile, you will do a urine analysis, then you will do a parathyroid hormone evaluation, you will do a SED rate, you will do a rheumatoid factor, you will do an ANA, and you do all this stuff to make sure that there is, because several of these conditions have so-called overlap syndrome associated with them. Namely, somebody may have rheumatoid arthritis, and because of the rheumatoid arthritis, they wind up having osteoporosis. But if you don't evaluate them by doing a SED rate or an NA or rheumatoid factor, you may never know that they have rheumatoid arthritis unless, of course, they have obvious deformities in the fingers and so on and so forth. Then you know that something is not right. Then you begin to evaluate that. After you've done all these different tests, and each one of these tests has a particular reason. What are you looking for? Okay, you do a vitamin D level. The vitamin D level is absolutely, completely crucial, because if you can't have low vitamin D for any extended period of time without having subsequently developing osteoporosis, because you need vitamin D really for a lot of things. People don't understand how crucial vitamin D is. And let me give you an idea. The vitamin D, 90%, as I mentioned, people of all ethnic groups that have dark skin has a higher risk of having low vitamin D. Very, very important. And vitamin D is one of the few vitamins that we actually can make in the body, even though we take it orally as well, but you could actually make it in the body. But the producing of vitamin D begins under the skin through the action of the rays of the sun that then begin the stimulation process that ultimately lead to vitamin D to 25. That then goes to the liver. When it gets to the liver, it has then to be processed to sent to the kidney. When it gets to the kidney, then it is the D125 that is that the kidney processes that make you vitamin D sufficient or not. It's crucial. So therefore, if you have kidney disease, by definition, you're going to have osteoporosis because of low vitamin D, because you cannot process the D125 that you need to remain in good vitamin D balance. On top of that, to make matters worse, 75% of people with dark skin, such as myself, has severe lactose intolerance, severe. And 55% of Caucasian, 55% of Asian, and 55% of other folks have also high incidence of lactose intolerance. That's very crucial, because once you have lactose intolerance, it means that you cannot take the dairy product, which is a very good source of vitamin D in your diet. Crucial. Now, let me give you an idea how serious these things really is, why it is important to check vitamin D level on everyone. For instance, 1 out of every 2 black adults, I call them Negroes, they call them black, African American, I call them Negroes, have hypertension. 1 out of every 3 general adults in this country, Caucasian, etc., have hypertension. 1 out of every 2 blacks have hypertension. Why am I making the point? I'm making the point because no matter what you do, low vitamin D causes an overactivation of the renin-angiotensin-aldosterone system. How about that? That's the system that controls the elevation of hypertension in the human body. So when we are treating people for hypertension, for essential hypertension, which is 97% of all hypertension, you must provide medication that's going to interfere with the renin-angiotensin-aldosterone system in order to treat the hypertension. How about that? But when you have low vitamin D, it overactivates that system, making it extremely more difficult to control the blood pressure. How about that? So if you don't understand these things, then you wind up hitting your head against the wall. Why I can't control the blood pressure? Why it's not being controlled? Forgetting that, or maybe a lot of folks, frankly, I hate to tell you that, didn't even know what I just told you. That low vitamin D causes overactivation of the renin, angiotensin, aldosterone system. You say, well, what do you mean, most people? Well, it's not everybody that's staying up 2, 3 o'clock in the morning, reading, searching, so that they can teach. Teaching is a very heavy-duty job, and the vast majority of the people who do the teaching in this country are doing it for no money. How about that? The vast majority of the teaching that's being done in all medical centers across the country are being done for no money because it is a requirement to being on the staff. Different doctors are asked to do different things for the medical center for nothing. Either working in the clinic to take care of folks who have no insurance or no doctors, and so on and so forth. So this is what's going on. I'm telling you, no medical center in this country, I don't know about the world, it's probably the same around the world, couldn't survive financially if they had to pay heavy-duty salaries for people to teach. So they make it part of the bylaw, you must do something. And people such as myself, who somebody have decided to have the ability to teach, are required to do it. And you believe it or not, you sign a contract. Every month when your month comes to teach, you sign a contract. And that contract means that you are on the hook for 7 days a week for that month period of time. And to make matters worse, patients who has no doctors who show up to the hospital is going to bill their insurance. That money, you sign an agreement, that money goes to the hospital. How about that? I mean, I realize I'm telling you too much, but you have to know these things because they have importance. They have serious importance. And also, the issue dealing with low vitamin D and people of dark skin, that goes right at the heart of the concept, which was just discussed this morning on the AMA website. Again, you cannot provide quality medical care. This is a classic example for people whose ethnicity and or the cultural background that you're not familiar with or you're not sensitive to. You just cannot. You can't make these things up. I remember having a discussion sometime last week in hospital that I wouldn't name, that I had a patient talking about hypertension. And the question of beta blocker came into the picture, and part of the discussion with me talking with some nurses. The nurses were shocked that every day they're prescribing beta blockers of one type or another for people who have hypertension. They were shocked when I explained to them, nobody, even the people who were ordering the medication, could not go on the blackboard with a piece of chalk in their hand and showed me the mechanism that allows them to have the nerve to prescribe the beta blocker for the hypertension. They couldn't do it, even for $1 million. And yet, it's being done. It was shocking. It's not shocking to me, because I've known this anyway. And the Anglo-Scandinavian study was done that proved hundreds of thousands of patients was included in that study. That shows that those that were getting beta blocker had more heart attack, more congestive heart failure, more death, because the only conditions that you could justify using a beta blocker for to treat hypertension is pheochromocytoma, which is a tumor that secretes adrenaline. You could block the adrenaline. Vascular hypertension in some instances. That is it. All of us who are in the general business of practicing medicine, sometimes we have the patient on proper, appropriate medication for blood pressure, but because they're working under intense pressure that's causing them to secrete a lot of adrenaline during the course of the day, we give them a small dose of beta blocker as part of the protocol treatment, the regular treatment, to shut down a little bit of the flow of adrenaline to help them. That's called hypersympathetic hypertension. But you can't treat that as a main medication to treat. It will not work. Even if it were to work, it will work temporarily. As soon as the kidney senses that the pressure in the human body is being dropped, it doesn't matter whether you're in shock because you're bleeding or you're in shock because you have a heart attack. It is the job of the kidney, my friend, to hold on to salt, to hold on to water, to keep the blood pressure up, to keep the body alive. How about that? So just because you treat somebody with something that might transiently lower the blood pressure, does not mean that's going to be the maintenance treatment. Now, you have to understand, of the one out of every two black folks in this country who have hypertension, somewhere around 28, 30% thereabout are getting the blood pressure treated properly. And people wonder why so many heart failures, so many heart attacks, so many strokes. My friend, that's your answer. Yesterday, the study came out. Again, the people that have the most hypertension, the most problem with the blood pressure, are people that are eating the most salt, the most fast food. And it gives you the percentage of poor folks in this country that are eating a poor diet. It's not their fault. It's not necessarily because of the cultural taste of it. It's because that is all they can afford. Yesterday, go and check the New York State website. Go and check the, this is happening every single day, and people are not paying attention. Somebody says something is good for something, they got a prescription for it, and bring the next patient. And when Valiere Alcena sit on television and say these things, the resentment is intense. Well, why don't they resent the AMA, who just came out today? Again, 33 medical schools have taken the grant from the AMA to try to help solve this problem of cultural sensitivity and ethnic sensitivity, to try to teach the new generation of physicians about this stuff so that they can provide better care. You can't make this up. Just last week, the AMA did one of those studies whenever they have their fancy meeting, great meeting there. They did a study again. They did it this year again. Give a group of senior medical students do a little research to know if they can know how to take blood pressure. They didn't pass because they didn't know how to take the blood pressure pump. This is disgusting. But this is happening every day. If I'm reading this stuff, thousands of other people are reading it, because I'm not the only one who get that information on my email. It's distributed throughout the country, throughout the world. You know, getting back to osteoporosis then, you can't understand how crucial low vitamin D is. And you can't talk about osteoporosis secondary to parathyroid disease until you make sure your vitamin D level is okay and normal. Otherwise, you're wasting your time. Therefore, then, when we do all these blood tests, what are you looking for when you look at the CBC? Look at the red cell. Is the patient anemic or not? That can raise a red flag. Is the patient WB white blood cell count is normal or not? That can raise a red flag. If the patient platelet count is normal or not, that can raise a red flag. If the patient differential count under the microscope normal, because the patient may have some hematological malignancy that causing them to have osteoporosis, such as multiple myeloma, to give you an example. And then so if you know hematology, you do the SED rate, the patient is anemic, the SED rate is sky high. You can't have multiple myeloma without a sky high SED rate. Right away the red flag comes up. So that's, I'll give you an idea, that's how the CBC will do for it. What is the chemistry profile is going to do for you? Well, you look at the patient blood sugar. Well, blood sugar can be associated with kidney disease. Oftentimes it does. Well, that's the importance of the blood sugar. Is the patient diabetic? You look at the patient blood urea and nitrogen. Is it normal? Is it abnormal? Is the creatinine normal or abnormal? Because if the patient has abnormal blood urea and nitrogen, or creatinine, that tells you there's kidney disease. Kidney disease is associated with what? Osteoporosis, secondary to low vitamin D. How about that? And then let's take a look at the urine analysis. What you can have, and also before even you go there, take a look at the patient liver profile. Is the LDH high? Is it normal? Because you can't have a normal LDH and have certain or most of the hematological malignancy. You can't, because all these tumors grow via the anaerobic pathway, and the end product of the anaerobic pathway is lactic dehydrogenase. So when your LDH is high, that raises a red flag. I said last week there are many other things that can cause the LDH to become, but I'm talking about malignancies. Okay, then you go and take a look at the urine analysis. What are you looking for there? Well, a lot of stuff, because when you have kidney disease, you could see a lot of stuff under the microscope. You could see a lot of stuff when you test the urine for a lot of stuff such as albumin. Albumin will be very high when you have kidney disease that are pouring protein out into the urine. So that's a value right there. Okay, and so you have to. So this is how you do that. Then I'm going to leave for a minute all this stuff having to do with blood tests, urine tests, etc. Before I do so, however, let's talk about the parathyroid hormone. You look at the chemistry. You look at the calcium. The calcium ordinarily is going to be high if you have parathyroid disease, primary hyperparathyroidism. But be careful; it could also be normal. Just because your calcium is normal does not mean you don't have primary hyperthyroidism. Okay, you do the potassium. You do the chloride. Well, why are you talking about potassium chloride, CO2? Well, you know, there's a condition called, I shouldn't be telling you all these things, but I can't help it. That's just the way it is. Renal tubular acidosis is a condition associated with all this stuff that I'm telling you about. You can have that problem. And if you know how to evaluate the electrolytes, and your red flag is going to become elevated, you have all the other stuff that are abnormal. What is the magnesium? What is the phosphorus? Well, I just finished telling you last week, the parathyroid gland, 4 of them sitting right here, a little above the thyroid gland, is in direct control of the serum magnesium level in the blood. How about that? So if your serum magnesium is high, what's going to happen? The serum magnesium is low, the PTH is going to be high. So when you see a high PTH, it does not necessarily mean that the patient has parathyroid disease. It may simply mean the magnesium is too low, so therefore the check that the magnesium has on the parathyroid gland has been released a little bit, so the parathyroid hormone can go up. It is your responsibility, I'm sorry to say, but it is your responsibility to know these things. If you don't know them, refer the patient to a specialist who do. The endocrine people know this stuff inside out better than I do. But you can't tag along until it is too late and all this thing was under your nose and you miss it. And I'm going to sit here just because of the resentment that I'm facing every day, because God gives me the gift. I'm not the only one who have this knowledge. This stuff is not, I don't have a monopoly to this stuff. But I have to know this stuff because I have to write these books. This one just came out, African American Men's Health, right here. I think it's 130-something chapters. I wrote it from the top of my head, except for a few statistics. And there's no other book like this in the world. That's it. I dare you to go online anywhere, find another physician anywhere in the world that has written a book like this. And I wrote it from the top of my head. That's right. From the top of my head, except for looking up a few statistics here and there. That's it. All right? And it's the only book of its kind that deals specifically with men of color. Why is that? Because the physiology is different. You can't take the physiology of the Caucasian individual and apply it to the physiology of the Negro. It makes no sense because there's huge differences. Huge differences. Because there's such huge differences in the physiology, the mechanism of different diseases, the reason for some of them are different. Therefore, the evaluation and the treatments are different as well. You can't apply it. You got 7 billion people in the world. 4 billion of them live in Asia. 1.5 billion live in Africa. That's 5.5 billion right there. And I haven't even talked about Europe and the rest of the world. And you want to apply the Caucasian model to all these people? Give me a break. How is that possible? Well, the powers to be now are finally agreed. It is not possible, and it is not proper. Because of that, 33 medical school in this country have taken the grant from the AMA to change things so that you don't have. What are you ashamed of? What are you afraid of? What's the big deal? Different human beings, we are all God's children. God make us with different color, but some things are the same. You could do surgery if you want to, because 99.9% of the time, all the organs are in the same place. The surgeon can find them. But you can't practice pediatric. You can't practice general medicine thinking that you're going to apply the same thing. Most of the research has been done using Caucasian model, the Caucasian folks. Very few black folks, very few women for that matter, are included in these things. And yet you're going to apply the same medication to them. How is it possible? Because people, frankly, are too egocentric and to have this crazy sense of superiority that they force that will on people. You accept it or leave it. But the time is coming now, according to the powers to be who run medicine in this country, to stop this nonsense, okay? To stop it. So that women are entitled to having the physiology taken into account. They're entitled to have certain medication that are good only for women. You can't push everything on them. The time has come to include all these individuals in the research setting so that when you're talking about certain condition, it could have application to them as well. All right? So those are the realities. So osteoporosis is not always just osteoporosis. There are many, many reasons why somebody may have osteoporosis. And therefore, you got to look at all the reasons, all of it, exhaustively. And then when if nothing else appears, then it is good old-fashioned osteoporosis. Then you begin to set up the dietary management. Then you begin to set up the treatment management, which I will talk to you in the next show, because the next show is going to be show number 4. Then I'll do a 4th show on this series and call it quit as far as osteoporosis is concerned after that. I didn't even get to the part of doing the radiological evaluation. In the next show, I'll go there to talk about the different radiological tests that must be done. And then after that, I'll talk to you about the medications that are out there. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.